Thank you so much for everyone for being here and for the honor of inviting me to be the visiting professor. When I saw who's coming next, I kind of got a little like, oh my gosh. Um, anyway, this has been a great honor. It's been a lot of fun going around the state. Got a new appreciation of Florida. I'm going to put some of my initial slides. Some of you, if you've been to some of the other talks, may have already seen, but I tend to start my talks all in the same way because I feel like I got to set the stage before I go and talk about something in particular. So my apologies if you've seen some of this before. Now I have to decide which clicker to use. Not that one. Let's try this one. Let's try this one. Whoops, wrong thing. Wait a minute. I clicked. There. Okay. That's good. And here. All righty. So now I figured out the right clicker. I swear technology is the thing that makes me super nervous. Bad trauma, I know what to do. Faced with two remotes and a keyboard, I'm in a state of panic. That's life, I guess. So my disclosures, I'm a member of the advisory board of a corporation called the Teleflex Corporation. Teleflex is a company that is trying to put freeze-dried plasma or market freeze-dried plasma in the US. I'm on the advisory board to remind them that children exist and that if you're going to put a product to market, that you need to have a pediatric indication as well. And so that's my conflict with that. And then I always like to say that I lived in Pittsburgh for a long time. It's sort of a disease. You become inflicted with that. And then wherever you go, you continue to bleed black and gold. That's my whole family sitting in the stands in the NRG Stadium in Houston to watch the Steelers lose badly to the Houston Texans. We were not, let me tell you, the only Pittsburghers in that stadium. About 50% of the stadium was kind of in full black and gold, waving their terrible towels and feeling depressed. So anyway, sports are fun. It's in Pittsburgh. It's a small city. It's gray and dark most of the winter. You got to have something to lighten the load. All right, so what I'm going to talk about today is about coagulopathy and then also some discussion about whole blood. And so to start off, I want people to understand the association of coagulopathy and poor outcome in injured kids. We're going to talk a little bit about viscoelastic testing, not because I think that everyone needs to be doing it all the time, but because it's provided us with some really interesting information about coagulation, and then talk about whole blood. But before I do that, I do like, as I said, to set the stage. Why do we care about this disease we call trauma? And in children, aren't they just small adults? Isn't this not really a big deal? And I like to remind people that, no, this really is a big deal in the pediatric population. In fact, proportionally, it may be a bigger deal in the pediatric population than in the adult population. If you look at this graph, and this says 2019, but that's just because I stopped making the slides after 2019 because they all look the same and I was getting tired of remaking the slide. But if you look at the top, there's a little blue box, and the blue box is unintentional injury. You will note that the blue box is the #1 cause of death in children up until I stopped making the slide. But actually, if you follow that little blue box, it's a leading cause of death in the US up until the age of about 44. And after 44, we start falling apart. That's my age group. Enough said. You'll also notice that there's some yellow or some green boxes and some red boxes on there. Green starting at the age of 10, suicide, and then the red boxes starting at the age of 1, but really starting to have a really significant impact in the slightly older kids, the older teens and young adults. And so if you start to add those little boxes together and you come up with a number, you'll recognize that injury probably accounts for over 90% of deaths in our adolescents, young adults. And so again, just put it in the back of your mind that if we want to have healthy, productive adults, we actually have to get them to survive childhood. And so this problem of injury, this disease of injury, we need to, 1, prevent it, and 2, once they have it, we need to be able to fix it better. This is something that I like to show because I think this should be disturbing to us all. I just took the intent out. So now we're not talking about the intent, unintentional homicide, suicide. We're talking about the mechanism. How did these children get injured? And the green line that has that nice sharp slope downward are the motor vehicle crashes. The blue line that kind of was flat and then kind of has an uptick are the firearm related injuries. You will notice in the red circle that firearms are now the leading cause of death in children. Think about that for a minute. Firearms are the leading cause of death in children. You'll also see, this is Pennsylvania data, and this is death rates per 100,000, but you'll see that over the course of time in Pennsylvania, we did some things to try to make that green line go down. So in around 2003, we had a booster seat law, and around 2011, a graduated driver's licensing law, and in around 2017, a no texting law. And as you can see with those public health initiatives, we made that green line decrease. And so the rate of motor vehicle crashes decrease. And you'll also note that there are no little ticks on that firearm line because as a community and as a culture, we haven't been able to figure out how to make some public health initiatives to decrease the rate of firearm injuries in children. This is again just looking at different mechanisms and age groups. I want to bring to your attention on the far left of the bar graph, the 1 to 4-year-old age group. You'll notice that the leading cause of death in 1 to 4-year-olds is that yellowish bar, drowning, something of significant importance in the state of Florida and also where I am now in Texas, where it's really hot. There are a lot of pools and kids are at risk of drowning. You'll see that after the 10-year-old, the blue bar of firearms, the orange bar of motor vehicle crashes start to be pretty significant. I do just want to highlight on the graph on the right that in the 10 to 14-year-old age group, the firearm suicides are equal to the firearm homicides. And even in the older teens, a third of the firearm-related deaths are suicide. Again, mental health is a significant issue in our pediatric population and part of this whole conversation and discussion about the firearm issue. And then just finally, we do have biases about who various problems affect, and sometimes it takes some data to kind of think about those biases. This was a study, this is not just in children, but it's just looking at firearm death rates in rural versus urban US counties, because there is a perception at least that firearms are an urban problem. And to the contrary, actually, this is looking at the rate, so not the total number, but the rate of firearm-related injuries in the most urban counties, which is on the left, to the most rural. And you can see that the most rural counties actually have the highest rate of firearm-related mortality, which I think is sort of surprising to us all. It's just that there are more people who live in urban areas, but if you take the rate, which is the number of people who, number of injuries divided by the number of people who live there, actually it's the rural counties that have a bigger problem. So just something, this isn't all of us problem and one that we need to think about it in that way. It's not just an urban problem. Oftentimes when I kind of jump between topics, I'll stick some of the injury prevention posters that we created over the years in Pittsburgh. And this was done by some high school students. It was a competition. This was actually a kid in their class who was in a bad motor vehicle crash. Don't drive distracted. Halos only look good on angels. So we're going to kind of back up a little bit and we're going to talk about where do kids receive emergency care? Probably kids account for about 20% of all ED admissions, and about 90% of those emergency department visits take place in a local general hospital. And probably about 80% of EDs see fewer than 10 kids in a day. So they don't see very many kids. They see them infrequently, and they certainly don't see very many sick kids. At a pediatric trauma center, like where I work, at least 50% of the kids that we admit are transfers. So they were treated somewhere else before they came to us. So the initial resuscitation of injured children is not usually provided by pediatric specialists. It's provided in general EDs or adult trauma centers. And so who cares? Well, this is the problem. Shock is really poorly recognized in kids. In adults, we kind of in our mind say that shock is equal to hypotension. But that doesn't work so well in kids because kids are actually really well-developed little machines. And they work really well. So back in medical school, nursing school, we learned a kind of equation that heart rate times stroke volume was equal to your cardiac output. So if you kind of just change that in your brain a little bit to say heart rate to some sort of nebulous concept I'm going to call intravascular volume ends up being your blood pressure, you can see how this works. So your child is kind of injured and they're bleeding. So their little well-constructed machine just increases their heart rate. And their heart rate goes up and their volume may be down, but they kind of maintain their blood pressure. And so they kind of truck along and their heart rate goes up. That's that blue line. And their blood pressure remains mostly pretty stable, and their cardiac output might go down a little bit. And then they fall off a cliff. And now they can't, now their heart is so empty that even though it's pumping really fast, there's nothing for it to pump. So now they get hypotensive. So clearly, we want to kind of identify, we don't want to identify shock here, when they're falling off the cliff. We kind of want to identify it over here somewhere, but that's hard. And so I think that that's the first problem, is that if we don't recognize that a child is in shock, then we're not going to treat them like they're in shock. And that is why I think one of the reasons that our kids are sort of difficult. This is Pennsylvania data. This is from the Pennsylvania Trauma Outcome Study, which is the state trauma registry. And we just asked a simple question. We asked, what happens if a kid presented to a Pennsylvania trauma center, not a Pennsylvania pediatric center, but just a general Pennsylvania trauma center, and they were hypotensive upon arrival? And basically, there was a 30% mortality. It's kind of a lot. And what if a child presented at a pediatric, or not a pediatric, at a Pennsylvania trauma center, and they needed blood in the emergency department? What we found is about 50% of those kids died, which isn't to say that that blood transfusion was the wrong thing to do. It just was like, gosh, probably they needed it a long time before they showed up at that trauma center emergency department. And again, remember, a lot of these kids travel all over the state. Dr. Hatch was in one of these places where got kids from all over the place before they finally came to his trauma center. In Pittsburgh, they traveled a long way before they got to me. This is a complicated study, but it was sort of answering this question. Well, okay, maybe they just need some volume. Maybe it's not really blood that they need, but maybe they need volume. So this was a study that looked at kind of what happened if you give kids who are in shock a lot of crystalloid. And it's a rather complicated multi-center study, but essentially it kind of showed that each crystalloid bolus after the first one was associated with poor outcomes: extended ventilator, intensive care, hospital days, and that delaying blood transfusion, giving more crystalloid, didn't negate your need for blood. It just meant you got more crystalloid before you got the blood. And so it suggested that, again, this is the military experience. This is one of my favorite things, that salt water is only good for making pasta. I think Dr. Schneider might have seen this slide before. This was a military study, and basically survival advantage. They showed a survival advantage of kids who received a high ratio of FFP to red cells during resuscitation. And that's kind of that 1-to-1-to-1 stuff. But then what they actually saw was kind of cool is that if you gave too much crystalloid, you negated that whole advantage. So again, the idea that the salt water isn't helping kids. Sometimes if it's the only thing you've got, then it's the only thing you've got. But if you got other choices, they're probably better choices. This was a consensus conference that we recently had, about a year, I guess it was published about a year and a half ago. And it was looking at a pediatric traumatic hemorrhage shock consensus conference and the recommendations. And basically the number one recommendation in traumatically injured children in hemorrhagic shock, we should suggest prioritizing the use of blood products over the use of crystalloids for resuscitation. So again, I think that this is now pretty well established in the pediatric trauma community, not unlike adults, but now we have data in kids to say that putting a lot of salt water is not a good thing, that go early to blood products. And what about pre-hospital transfusion? Hot topic, I know, in the state of Florida. This is not a whole blood study. This is just a transfusion. And this was a propensity match study using, again, Pennsylvania Trauma Registry data. Before matching, there was a higher mortality in the group that received pre-hospital transfusion. Big surprise, if you're getting blood pre-hospital, you're probably sick. But after matching, there was a significant reduction in 24-hour mortality and in-hospital mortality, and the number needed to treat to reduce an in-hospital mortality was 5. So pretty low number needed to treat if you look at that type of statistical modeling. And again, this was any blood products. It wasn't necessarily whole blood. So we'll get to the whole blood data, but this is just to say that one should not, if you don't have whole blood, that's okay. They need some sort of blood product. Don't, the salt water probably, if you have a choice, blood product, salt water, blood product. Swallowing button batteries can be fatal. This was a billboard that we put up. I think this has also been under discussion around here. So what about coagulopathy? In adults, this is part of the vicious triad: hypotension, acidosis, and coagulopathy. And there's certainly a lot of overlap between the coagulation and inflammation pathways, suggesting that coagulation probably isn't just about bleeding, but it probably has something to do about inflammation and, in general, response to injury, as opposed to just bleeding. I love this because this is the kind of thing that they make you memorize in medical school and you promptly forget. There are too many arrows going in too many different directions. It's like, okay, yeah, it's complicated. That's basically what this means to me. But there's a lot of things that are happening. There are platelets. There's the vascular endothelium, which is not just a passive lining of a tube, but is in a very active organ. There are coagulation factors. There's hormones like catecholamines. There are inflammatory cytokines. There's fibrinolysis, and we'll talk a little bit more about that. We asked a very simple question a while back, and we said, okay, how common is coagulopathy in injured kids, and who cares? And so the first thing that we learned, and the study population we used were kids were admitted to the ICU. We decided that if you were sick enough to be admitted to the ICU, that put you as sick. And so what we found is that coagulopathy, defined by an INR of greater than 1 point or equal to 1.3, so not a normal, an abnormal INR. About 30% of our kids presented with that, and they had a pretty high mortality, about a 10% mortality, which again, in a pediatric trauma cohort, that's relatively high. And then we started to do odds ratios for prediction of mortality. You'll see in that first column, that's an odds ratio of greater than or equal to 1.3. That is not something that we would ever think about treating as as someone at risk for bleeding, but it's a marker. It's showing us that there's something not right in that patient. That elevated INR had the highest odd ratio of predicting mortality, higher than hypotension, hypothermia, acidosis, the injury severity score, even the head AIS score, or even being in a hemorrhagic injury. So again, a very strong marker of mortality. Most of these kids are not bleeding, but it's a marker. And so this is just looking at a staircase. If your INR was normal, 2% mortality. In that slightly abnormal, but clearly not clinically significant in terms of bleeding, 10% mortality. Higher INRs, 1.5 to 1.7, a third of those kids died. And if you had a really abnormal INR, 2/3 of those children died. So again, this was a pretty strong predictor of mortality. Brian Cotton from Houston asked the question at one point of what kinds of laboratory markers upon admission were associated with 100% mortality in pediatric trauma, and an INR greater than 3 was in that category. It's sort of an interesting paper. It's sort of an interesting paper for futility. Like if kids come in looking like this, you can give some pretty strong counseling to the parents. This is a paper we're looking at to try to help us understand maybe why this is happening, because again, these are not that INR isn't a treatment target, but there's something going on, and we think that a lot of what's going on may be this endotheliopathy. So again, that endothelium, the lining of the blood vessels, is not a passive organ. It's doing something. And there is a protein on it called syntagon 1, And we demonstrated in this particular paper that the elevations of that were suggestive or were associated with injury and poor outcome, and associated with increased INS. Elevated SIPA is the shock index pediatric adjusted on admission and poor outcome. And so we think that that marker of an elevated INR may be traced back to some abnormality with the endothelium, leaking membranes, and so on. But still in progress. These are sort of hard studies to do because they require a relatively large amount of blood sometimes, and our little people don't have that much, and our IRBs don't like us to take that much, and so on. The adult studies that we you look, 20 cc's of blood were taken at time 0, 6, 12, and I'm like, that's my kid's blood volume. All right, let's see how we can do this with less. All right, so we wanted to know how to better understand coagulopathy. Elevated INR we associated with increased mortality. Fixing it, we showed in some other things. If you dumped a bunch of FFP, it didn't really change that predictive value. And so how can we better understand the physiology? And so we were doing some work with viscoelastic testing, and we started to look at this as kind of maybe a way to better understand coagulopathy. Viscoelastic testing is basically using whole blood, and you actually look at clot formation, which is that sort of stem, the maximum amplitude, how strong the clot is, and then you watch it degrade, and that's called fibrinolysis. And it can give you information about clotting factors, platelets, and then again, clot degradation or fibrinolysis. And we have a nice little TEG and resuscitation algorithm where if we have different values, we give different products. But we really were so that was the clinical side. But then we asked a bunch of research questions, and we wanted to know whether this could help us understand this coagulopathy a little bit better, and what aspect of the clotting process was most significant in injured kids. And one of the things that our traditional clotting tests don't give us any information about is hypercoagulopathy. And we all know that there, at some point, we have injured patients who are both at risk of bleeding and at risk for DVTs or too much clotting. And so we kind of wanted to see if TEG could help us give us some information about that as well. So we did a principal component analysis, which is basically a statistical methodology where you put everything into the soup and you figure out what is most significant. I'm obviously oversimplifying, and I am not the statistician of the group. But we basically kind of found that this fibrinolysis domain seemed to be the one that was most associated with severely injured and all of the poor outcomes that we were looking at, which included mortality, needing a transfusion, a DVT, or a disability. And disability in some of our work we've defined as either an abnormal FIM score or sometimes the presence of a gastrostomy tube at the time of discharge. And so fibrinolysis is natural, it's normal, we all do it. If not, we would be clotted, right? Because if you form clot, you have to break down. It's kind of like wound healing. You form a clot, you kind of fix the vessel, then you break down and you remodel that excess clot, and that process happens all the time. But if you do it too much, you're going to not plug holes and you're going to bleed too much. So hyperfibrinolysis can promote bleeding. And if you don't do it enough, you're going to clot too much. And so then you're going to have potentially thrombotic complications or potentially even microthrombotic complications. The adult literature has shown that both of those things are bad, that hyperfibrinolysis is really bad, but the too little breakdown or shutdown is also not good. And so we wanted to know what the impact of fibrinolysis or fibrinolytic abnormalities were in injured kids. And again, primary outcome was death and disability. And what we found is that it was really pretty strongly correlated, that an abnormal fibrinolysis, so meaning either hyper or hypo, if you combine those together, there was about a 30% mortality. And in kids who had normal fibrinolytic markers, that was about less than a 2% mortality. And then for some of our other adverse outcomes, again, that abnormal fibrinolysis was highly correlated, and even DVT. So again, too much bleeding, too little bleeding, about a third of the patients had DVTs. And I'll just, the DVT numbers, people are going to go, you're a pediatric trauma center. You're not supposed to have any. At this point in time, we were doing a lot of screening. And so we were picking up a lot of probably subclinical DVTs. We stopped doing that at some point, which was probably better for patients, but worse for a research kind of related outcome because that marker wasn't there anymore. Such is life. One of the limitations in that particular study is that was just the admission that we got. It was standard of practice that we got a tag on upon admission, and so we got some funding, and we started to get daily tags, mostly just to follow and see how they were changing. And what we found was pretty interesting, and particularly in kids with severe TBI. And when they came in, they were sort of on aggregate, their fibrinolysis markers were pretty normal, or at least in the normal range. But every day after that, they were in this sort of hypercoagulable shutdown phase. And that was clearly different than the kids who didn't have TBI. So it seemed like there was a different process maybe going on. And we have a lot of TBI in children, and that's the leading cause of traumatic death in kids is TBI. So then we said, okay, well, that's interesting. But when does this happen? Does it, and so we took advantage of a natural experiment. I like natural experiments because I think it's kind of cool when you can use things that happen normally. I like to say my laboratory is the hospital, and I can't control things, but I can ask a question in a way that I get information from the way things naturally happen. So I told you that about 50% of patients who show up at a pediatric trauma center are transfers. And so that meant that their injury happened a long time ago. I may not have mentioned that, but almost none of them receive blood products before they get to me. And you could kind of get that implication from some of that Pennsylvania data. So the natural experiment that I had is that I could look at time of injury and time from when they got sort of that first initial tag. And it wasn't really colored by them having received other types of medications, particularly blood products, and none of these kids received TXA. And so I could kind of get an idea of whether you got your tag within an hour of injury, under 3 hours of injury, or over 3 hours after injury. And those of you who know the TXA literature will understand in a minute why I picked those time points. So what we found is if they showed up and we got that initial tag within an hour of injury, most of them were in that physiologic range. There were some that were starting to show some of that shutdown physiology, and there was a relatively larger proportion who are in that hyperfibrinolysis. 1 to 3 hours, the shutdown was becoming more predominant, and after 3 hours, the majority of them were showing that shutdown physiology, suggesting that perhaps they were moving into a more hypercoagulable state than a hypocoagulable state. Traumatic brain injury, this was really pretty interesting because there's a lot of work about, FFP or plasma early in traumatic brain injury might be protective. And TXA in traumatic brain injury, there's been some issues or some signals that might be protective. And so what we found was in less than an hour, these kids seemed to show almost an early activation of the fibrinolytic system. And so they're a little bit more hyperfibrinolytic, not terribly, but maybe a little bit more. And then after an hour, they kind of flipped into the shutdown. So it's a dynamic system. It's not all the same, but it seems like there's some changes that are happening early after injury. So what are the implications? The TXA data, the TXA administered under 3 hours had a survival or a mortality advantage. After 3 hours, that didn't seem to have an advantage, possibly hypercoagulable complications, and that's in adults. And so to me, it's sort of the implications of some of this data. And again, this is pretty preliminary data. This isn't like a huge study. This is just what we saw. But that antifibrinolytics might be detrimental in patients already in shutdown. So if they're already looking hypercoagulable, might not be helpful, but it might be helpful prior to they start to make that progression. And perhaps the window for intervention in kids is early, and really maybe for most bang for the buck might be within the first hour of injury. And I just always want to make this caveat is that not all TBI is the same, and abusive head trauma is not the same. And why is abusive head trauma not the same? Well, for this discussion, we don't know when the injury happened. I told you, we knew the time of injury and we calculated back and we knew when we got that first tag. But with abusive head trauma, we have no idea when that injury happened, and we have no idea whether it might be multiple injuries and not just one injury. So that is a separate population that kind of lives, so to speak, in the parking lot. Really interesting in and of itself, but one can't extrapolate this data to that patient population. There we go. And so let's just talk about TXA a little bit. There are multiple adult studies. CRASH 2 and CRASH 3 were in adults. STAMP is the pre-hospital TXA mortality benefit greatest in the first hour after injury, and that's an adult. And then there's Matt Borgman did this. This is a military study published a few years ago. But basically, the separation of on the left-hand graphs where there's a separation of those mortality curves, that was when the TXA was given early. Delayed TXA, the mortality curves are the same. So again, it's the suggestion that early TXA may be beneficial, delaying it may not be beneficial. What about in a antifibrinolytics in a pediatric civilian cohort? So this is from a massive transfusion database. This was bleeding of all etiologies, including traumatic bleeding, medical bleeding, and surgical bleeding. And the reason it doesn't say TXA is this was antifibrinolytics, which included both TXA and Amicar, which supposedly works in a similar fashion, and showed a decrease in mortality at 6 and 24 hours post-bleed if the patients who were undergoing massive transfusion received either of those medications. The average time that TXA was given after the bleeding event was about 66 minutes. So again, seems to be that it was being given sort of within that, what I'm going to borrow as a term of that golden hour. And so that early administration. So I think to me, and there's lots of questions, I'm happy to kind of give my thoughts about TXA in more detail. I think there's definitely clearly a survival benefit in adults with hemorrhage. I think there is a potential benefit in kids with hemorrhage. I think the window of administration may be a little narrower in children, and there is a randomized trial that hopefully will answer this question, although I think so much TXA is being given pre-hospital that we may have lost our opportunity there. The other thing I will say about TXA, it's a pretty safe medication. It's been given to kids for a long time. It's been given to kids in the operating room for things like congenital craniosynostosis surgery and for spine surgery. So it's not like this is a new medication and never been used in kids. It's just that this particular indication has not been particularly well studied. Fire escape plans save lives. What's yours? So just briefly to review, shock is difficult to recognize in injured kids. Severely injured kids are usually under resuscitated, especially with blood products. Traumatic coagulopathy is frequent. It's bad. We don't really understand the pathophysiology, but it seems that it happens starting early after injury. TXA is potentially a beneficial adjunct in bleeding children. So what should we be doing? Well, we should be identifying shock early, minimize crystalloid in acutely bleeding patients, obviously stop the bleeding. I mean, that's sort of one of those no-brainers that we can give all the products in the world, but if they're continuing to bleed, we're not going to win this particular war. We need to stop the bleeding. Transfused blood products, consider TXA. Transfusion should be as close to the 1-to-1-to-1 ratio. I didn't show that data, but there's plenty of data in pediatric populations to support that. And of course, the challenge is that blood products aren't all available at the same time, and that's particularly true in children's hospitals where blood transfusion is not as common. Does expose kids to multiple donors, and there's a potential for clerical error. So, the potential solution, what's old is new in whole blood. This was the product that we initially used in Pittsburgh. Group O negative, whole blood from male donors. The male donors decreases the incidence of transfusion-related acute lung injury. It was cold stored, which means it was just thrown in a refrigerator. It was low titer anti-A and anti-B. Initially, it was less than 50, then less than 100. Now it's probably less than 240. We have a very kind of blood bank, and so they tend to preferentially route the O negative and the very low titer to the children's hospital. So that's why we were able to receive those products. We leukocyted reduced and using a platelet sparing filter. So there's balance. Whole blood, kind of makes sense. I mean, let's face it, bleeding blood, give them blood. I mean, it sort of it makes sense to the, but we think it's certainly a potentially a more physiologic resuscitation, fewer donor exposures, decreased risk for medical error, 1 bag versus 3 bags. It's easier to administer. You spike 1 bag, you don't have to spike multiple bags and check multiple bags. For kids, this bottom point I think is particularly important. It's a lower total volume. And in kids, sometimes we can really volume overload kids by giving them all these different products. And there's fewer preservatives. And those preservatives can cause us problems. They chelate, the citrate can chelate the calcium, which leads to the hypocalcemia, which independently has bad outcome. Multiple stored blood products release a lot of potassium, and we definitely have had kids who have had hyperkalemic arrest because of the blood products that they've been receiving. So again, these are not insignificant issues with kids. What is the risk? The major risk of whole blood is hemolysis, that you're going to have that the antibodies that are contained within whole blood are going to interact with the patient and cause hemolysis. That only happens if the recipient is a non-O recipient. O recipients won't have any antibodies, but a non-O does have some antibodies, and you might have hemolysis. And so, but that's the major risk of whole blood compared to others. There is also the concern about Rh sensitization, and we're going to talk about that a little bit, but that's when if an O negative patient received Rh positive blood, and it does require specially prepared units. This is from a blood banking perspective, and blood bankers are not bad people. They have a blood supply, which is a very limited supply, and lots of people who need blood. And so if you take a unit of and prepare it to be whole blood, that means they are now down to products, right? Because that unit of whole blood could have been platelets and FFP and red cells and gone to 3 patients, but now it's 1 whole blood unit. So that's where some of the blood banking issues are with whole blood, and that they do have to specially prepare the units. There is a potential for waste. Its shelf life is not as long as components. Now, there's been some studies to try to extend the shelf life of whole blood as well, but if you don't use it again, you could have potential waste. But I think the big thing is, does it work as well as component therapy? If it doesn't really have any advantage over component therapy, then maybe we shouldn't be putting our blood bank through all this stuff to produce it. So that we did a lot of safety studies. We started a whole blood program in Pittsburgh in 2016, and every patient received hemolysis labs and was followed pretty closely. And so the first thing is that when we compared our group O patients recipients to our non-group O recipients, group O recipients should have no hemolysis. The risk of hemolysis is in those non-O patients. There was no increased hemolysis. That was safety, sort of that safety one. And then for secondary outcomes, we looked at, maybe there was a difference between our O recipients and our non-O recipients in mortality, disability, hospital length of stay, and whatever. And there was no difference. Again, this is just pure safety data. And then we started to look at adverse events. And so this was using propensity matching, where we took a group of kids who had component resuscitation versus a whole blood resuscitation. We did some propensity matching so that we had 36 in each arm. And then we looked at end organ dysfunction, because there was a sense that maybe if they were having microhemolysis, that there might be more end organ dysfunction in our whole blood group than in our non-whole blood group. And so we looked at a bunch of stuff, and essentially there was no difference between the groups. Again, another safety outcome. There was a period of time where people were really concerned about the platelets. So, you remember back, or if you've ever taken a tour of your blood bank, the platelets are in a special area, and they're on these little machines called agitators, and they're gently agitated. They're room temperature, and they're gently agitated, and so they're special. And I'm telling you, we took this bag and we threw it in a refrigerator. So they're A, cold, and B, not being gently agitated, and people were concerned that they wouldn't work. There's some data to suggest that actually cold platelets are stickier. They may not last as long, but they're stickier than warm platelets, which for trauma would be a good thing. And we did a very little study where we looked at some kids who got whole blood and some kids who got a platelet transfusion and had tags and a platelet count and a tag done afterwards. And we basically showed no difference in the platelet count of patients who received a platelet transfusion versus those who got whole blood, and no difference in platelet function as measured by tag. So suggesting that our cold platelets were functional and as good as the platelets that people were getting when they got a platelet transfusion. People have also said, well, okay, that's fine on those big kids, but what about the little kids? And so we had a cohort of kids that were less than 20 kilos that received whole blood during resuscitation, median weight of 12, age range of 29 days to 5 years. And again, no transfusion reactions or hemolysis reported. It seems to be safe in all age groups. And so again, that's sort of the safety data that you can bring back and say, this seems to be safe. Well, we don't really, I mean, we care about safety, obviously, but we really want to know about outcomes, right? And so this was our first whole blood experience. This was published in 18. And this was a really sick cohort of kids. And I wish I could say that that was a survival Kaplan-Meier, but it's not. It's an efficiency Kaplan-Meier. That we were at a children's hospital that had packed cells in the emergency department, thawed plasma available 24/7, and obviously platelets in the hospital. And the top line is how long it took us to get those 3 products into a bleeding patient. That is not particularly spectacular. The other one, the 16 minutes, is how long it took us to spike a bag of whole blood that lived in the emergency department and give it to the patient. If that's the only advantage of this, is that it's a conveniently pre-mixed package that we can give someone faster, maybe that's all we need to say that this is better. But again, that was just an efficiency. We did some propensity matching, and we looked at a cohort of kids. Again, I told you that we did this, a cohort of kids who received whole blood and a cohort of kids who received component therapy. And we showed that the time to resolution of base deficit was faster in our whole blood kids, suggesting that we had an earlier resolution of shock. And we also showed that at 24 hours, their INR was lower than the kids who received components. Now, I find because I'm a coagulopathy person, I find that really interesting because I can't tell you, I don't have the interim time points to tell you whether we prevented the coagulopathy from developing at all or whether we treated it better. And so I think that that's sort of interesting. But the holy grail, can this save lives? And so the military experience definitely suggests yes. Hazelton in 2022 published a large prospective observational study of whole blood versus components in adults and showed that with the recipients of whole blood were 48% less likely to die. That got everyone's attention. This was a TQIP study from 2020 using 2017 TQIP and basically showed no difference in mortality or major complications, but a decrease in total amount of blood products given, which is another, if you go through the whole blood literature, is another outcome that seems to be pretty consistent. And if you think of blood as being a very scarce and rare, valuable resource, if you can do a way of giving less of it, maybe that also is an advantage in and of itself. This was our study that we published in 2021, 2022. And so we looked at patients that were most likely to have a mortality advantage. So a patient who just received 1 unit of whole blood probably wasn't going to die. We felt that they might have had better outcomes, but that patient probably wasn't going to die. But what are the patients who are going to receive a massive transfusion? Those are people with life-threatening bleeding. And so maybe those are the patients that we should really focus on if we're looking to see if there's a mortality advantage for something. And so this was, again, another propensity match study. And this is our Kaplan-Meier survival. And this shows that with the kids who received our low titer whole blood, that we have an improved survival at 72 hours and at 28 days. The 6-hour time point, we just didn't have enough deaths at 6 hours to have any statistical say in whether a 6-hour time point was useful or not. All of our early deaths were mostly secondary to hemorrhage. Late deaths were all secondary to TBI, and that's this dark, the bar graphs, cause of death by time period at 72 hours And at 28 days, these were the TBI deaths. And so it seemed like the whole blood was making an impact in preventing the hemorrhagic deaths, but the kids who were going to die of TBI died of TBI. Parenthetically, in Pittsburgh, it took us a long time to declare someone brain dead because of various and sundry process things. And so that's just an aside. This is another TQIP study. This one was a later one. So it's kind of interesting as you keep looking at dipping down into TQIP. So this is TQIP 2020 to 2021. The last one was 2017. And using propensity scoring, and they saw a 42% lower risk of mortality in the pediatric cohort who received whole blood, which looks remarkably similar to Hazelton's 48% decrease in mortality in that prospective study of adults. So it appears that the inflection is similar. These are just some other papers on the topic that have come out: balanced resuscitation with whole blood versus component therapy in critically injured pre-adolescent kids. Getting there faster, fewer exposures, Dr. Snyder. And whole blood was associated with faster time to balance resuscitation, fewer transfusion exposures, and lower blood product volumes. So again, some of those other outcomes, which may not be the holy grail of mortality, but may make enough of a difference in our trauma centers to make it worthwhile. Assessment of the safety, hemostatic efficiency, and clinical impact of low titer group O whole blood in children and adolescents. And again, there may be a mortality benefit. Larger multi-center studies are needed. I'm trying to talk fast. Okay, the RH issue. And then this is one that I think is another hot button item. So O negative is a relatively uncommon blood type. About 7% of the population is O negative, 38% of the population is O positive. And why is it a problem to transfuse O positive blood? Well, it's a risk for females who are Rh negative because the exposure to those Rh positive red cells could result in alloimmunization to the Rh antigen, which could result in future loss of an Rh positive fetus through hemolytic disease of the fetus and newborn. And the mechanism is that those maternal anti-D antibodies can cross the placenta, bind and destroy the fetal red cells. And this is a bad problem, and it can cause severe, progressive, and ultimately, if untreated, fatal anemia. So you have to ask, risk is all risk. And so you have to sort of estimate the risk. And so what's the incidence of Rh negative in the general population? Caucasians is 15%, and they have the highest rate of Rh negative. African Americans, 8%, Asian, 1%, Native Americans, 1%. So most girls who present or women who present to the emergency department are going to be Rh positive. There's only a small population that's Rh negative. Not all Rh negative patients who receive Rh positive blood become alloimmunized. Only 60% of the fetuses in Rh negative women are actually Rh positive. So not every pregnancy that woman has is the fetus going to be Rh negative and have the problem. So the probability of an Rh negative female receiving Rh positive whole blood, ultimately having an infant, this starts to sound a lot like who a severe hemorrhagic disease of newborn is pretty low. And the mortality is high in children who need blood, and its administration is delayed. So one could say, kind of change the ethical dilemma around and say, is it ethical not to give a girl who might be bleeding to death, who we've already said if may have a somewhere around 50% mortality, and not give her something that we think has a mortality advantage to prevent a 0.7% chance that she might have a baby that has a problem. So again, it's just the way you look at a problem, but risk is something that is always hard to estimate. This sort of little staircase is published in Journal of Trauma in 2023 if people want to look for it and kind of think about it a little bit more. We've actually asked parents what they think. And so this was something that we published recently on parent perceptions of emergent blood transfusion in children. And so we asked parents, okay, here's the risk that your child, your child is showing up in the emergency department, they're bleeding. We have this product that could do this, and we think it might be a little bit better than this product, but it has this potential adverse outcome. And most parents were willing to accept RHD positive blood products on behalf of their RH negative female children in an emergency situation. I mean, it's a really hard thought experiment to ask parents, but at least we did. I mean, we were starting to ask the question, and in general, parents were like, save my child, kind of, we'll deal with the other things down the road. Um, so there is some data on this issue. So in conclusion, or almost conclusion, there's a lot of limitations in this published data. First of all, most of it is all retrospective. And so there's data quality issues and bias issues. If you start to read a lot of this literature, you have to be really careful because there are a lot of different populations, penetrating trauma versus blunt trauma, TBI. They're all kind of mixed in. Some of them, they're separated out, some of them not. You just have to know what patient population is being talked about. Type of center is also all over the place, adult, pediatric, mixed, and military. The product that they're giving is not always the same. It's called whole blood, but if you read the details, it's not always the same product. In some of the military studies, they're using sort of the Holy Grail, which is fresh whole blood that they, one soldier gives to another soldier. That's different than the stuff that I've said has been sitting in my refrigerator for a couple of weeks. Cold stored, leukocyte reduced. A lot of the Houston data, or in most of the Houston data, is not leukocyte reduced. They don't take the, they feel that the platelet sparing filter does not spare the platelets. And so much of their data is not leukocyte reduced. So it's just a different product. It may be the same, it may be different. Antibody titers and RH titers. Use of adjuncts such as TXA, and there's also variable volumes of whole blood administered. In some of our early work, we were only administering 10 or 20 cc's per kilo, and sometimes it's hard to say that that's going to make a difference in mortality. So again, a lot of variability in this literature. I think that whole blood is an efficient way to empirically achieve a balanced resuscitation and that it's safe. I think that there's a lot of data to suggest that we use lower total blood product administration and that it's more efficient. And there may be a survival advantage. What we don't really know is the exact population of kids who would benefit the most. Which brings up this, which is a randomized, multi-center clinical trial, platform trial, 2 domains, whole blood versus components. And then the second domain is hemostatic agents, TXA versus placebo, 20 to 24 high volume academic medical centers. And this is funded by BARDA, which is the Biomedical Advanced Research and Development Authority, which is part of Health and Human Services. The study is funded at about the tune of 38 million to get us through it. It should begin enrolling patients in October. I'm a little concerned that some of the cat is already out of the bag, that I think it's with pre-hospital giving TXA, it may be hard to get patients who are naive when they get to the trauma center to be entered into a randomized study. And that's one of the problems with randomized studies, right? They're really expensive. They take a long time to get off the ground. And sometimes our practice changes before the results come out, for better or for worse. With that, this is my team from Pittsburgh. Starting to amass the team in Dallas, but I'm still, as I said, I still bleed a little bit of black and gold. And thank you all for paying attention and being here. And again, thank you for the great honor of being the visiting professor for the state of Florida. And I'm happy to answer questions.
I will walk around with the mic if needed, or at least help with that on this side of the room. But Dr. Gaines, thank you for an excellent presentation. And I have one question just to kick things off. Is there any difference in the mechanism of injury for children? In children, as we know, the incidence of penetrating injury is lower than adults. But when some of the comparisons for use of mass transfusion resuscitation adults versus kids. You briefly mentioned abusive head trauma, but just as far as blunt versus penetrating in a child who is in hemorrhagic shock, does that factor in at all?
I mean, when you look at some of the studies, I think some of the studies have been looking at predominantly older kids, and there's a lot of penetrating trauma there, and there may be a difference. I mean, if you think about it, for coagulopathy, there probably is a little bit of a difference because blunt trauma suggests sort of endothelial disruption all over the place, whereas penetrating trauma is probably a hole. And there's different fibrinolytic patterns. So I think there may be a difference. I'm not sure that we know what that difference means. And some of the military data has a lot more blast injuries than civilian blast, and penetrating issues than some of the civilian injuries tend to be sometimes more lower energy mechanisms, falls. We see a lot of pedestrian struck motor vehicle crashes. So maybe there's a difference. I think we just don't know, and that's why with some of this data, again, there's a lot of lumping in order to get numbers, and maybe we lose our precision to saying who's really going to benefit from what intervention because we lump them all together.
A great presentation. Two questions. Number one, your presentation suggests that there may be a different inflammatory response of a child based on age, and you use 40 kilos as a differentiation. Do you think that there is? Do you think there's still a time period where they yet to mature their inflammatory response?
So I'm not sure that there's a 40 kilo, but I think that we don't know. And so some of the work that we're doing is kind of taking a look at those different age groups. Is there a difference in the young child where we know that there are some immaturity of their coagulation/inflammatory systems? What about the role of sex hormones? Does puberty cause an inflection or a change when suddenly kids who basically are sort of hormone naive start to have hormones? And so we're starting to look at that. And so I think that that's part of the soup. I think where we have been, for the whole blood discussion, it was mainly just a question, is it safe in really young kids? And we started with older, bigger kids because of some delusional things in our blood bank. And our colleagues felt like that would be a population where their blood volume was big enough that if there was some low-grade hemolysis, they'd be okay. And as we started to see no hemolysis, we backed down on the age. And at this point, think that it is safe in all ages. But I suspect that there are some subtle differences in coagulation as kids age. I don't think we haven't defined it very well.
And the second question is a lot of us tend to use Cotton's ABC criteria for indication for transfusion. Is there a pediatric version?
Yeah, no. There's been some ABCD. I mean, there have been some attempts, but they haven't been validated. Sometimes people will add a lactate on there, and sometimes a disability. So ABCD for disability, and then a lactate to try to encompass some of the head injury patients. Because so few kids, proportionally fewer kids, have penetrating injury, and that's one of his major categories. It's sort of, again, it doesn't work. It doesn't function quite as well. SIPA plus a lactate seems to work a little bit better. And so I think SIPA, or the shock index pediatric adjusted, at least gives pre-hospital a way, instead of having to remember what's a normal heart rate for all these kids, it's just kind of rapidly making a ratio of heart rate to blood pressure and seeing if that's appropriate. And I think that can be helpful to try to, at least in the early identification of a kid who's looking like they're in shock, as an indication for transfusion. None of these things are particularly have a great positive predictive value, but I think that they can at least help us start to, if you don't think that the kid's in shock, you're not going to treat for shock. If you start to think that the kid is in shock, then you're going to look at other things, and it's a heightened awareness, and maybe that child would benefit for earlier transfusion.
Can you comment on the use of whole blood in the pre-hospital setting for children?
So there's some places that do it. I think if you have it, I think it's great. I think it's just going to be, it's harder. I think it's just harder for people to do it. And so it hasn't been done very often, but again, I think the work that we've shown is the earlier you get at least a blood product into a child, the better. And so I think if that blood product happens to be whole blood, that's great. It's just that up until now, most pre-hospital weren't carrying whole blood. I already talked about the RH thing, but the other barrier that a lot of places were using is that they wouldn't felt uncomfortable giving RH positive whole blood to girls who were injured. And I think that there's supporting both ethical and, at least some survey data to suggest that that's probably okay. Probably worth a discussion with the family after the fact, but I think most families would be happy that their child received what we thought was the best care, and then, potentially deal with complications down the road.
Let's just do two more questions and please introduce yourself.
Hi, my name is Laurel Sinclair. I'm from Memorial Regional, one of the TPMs, and Joe DiMaggio Children's Hospital. So in your data on tick, you noted that the INR result of 1.8 or greater resulted in a 64% greater mortality, and an INR of 3 or greater is 100% mortality. Has that changed your practice, or has anyone taken that data and done anything? Because that seems to be like a significant marker for mortality in pediatric population.
So the way I use it is it changes my discussion with the family, and maybe that idea of futility. It probably doesn't mean that I'm not going to resuscitate, but it changes my discussion. The last kid that we saw was a kid who window fall landed on on his head, concrete, and came in with an INR of something 5, that terrible traumatic brain injury. And we could sit down and have a conversation with his family about things like do not resuscitate, and really begin those conversations a lot earlier than maybe we would have. So I think it gives us as providers a little bit more data of how to have start having those difficult conversations. I don't, with any single, and it's not a single number of isolation. The head CT looked horrendous, but again, it's just supporting data that this child has decompensated completely, and now nothing is working.
Dr. Gaines, thank you again for being with us for that amazing talk and your pioneering work in helping injured kids. Got a lot of questions. I'm going to limit it to just one in the interest of time for right now. But when your pre-hospital providers come to you for like a specific age and weight cutoff, because they have to have very concrete protocols and stuff like that, given the current state of the science for kids in pre-hospital whole blood, is there like a specific age or weight or any criteria you would give them?
I don't know for pre-hospital whole blood. I thought you were going to ask me about TXA. I don't think that I have a pre-hospital whole blood, because I really do think of whole blood pre-hospital pretty much like a blood product. And so if you are lucky enough in your ambulance to have, or your helicopter have whole blood, I think I would give that whole blood. And I'm not sure that I would put an age. I don't have an age limit on that. I think that as a blood product to give to a child, I think it's produced. Giving it to a 28-day-old. So I don't feel uncomfortable with that. I have a little bit more, to be honest, discomfort with TXA, only because I think that there's a lot going on pre-hospital, and one of the things that it's the whole multiplication thing. It's 15 to 25 milligrams per kilogram. So you have to know what the kid weighs. They're sick. They're doing a bunch of other things, and so that one I have a little bit more. And some of the kids with pure TBI or kids who are seizing, I'm just not sure that that's what I want them to be grabbing at. So that I have a little bit more discomfort with. The younger child, I think over, 10, 12, whatever, I think it's fine. I think it's for the younger child where medication errors are high, and there's already a lot of stress about the care of that very small patient that maybe TXA wouldn't be the first thing I'd be reaching for in my medication drawer. blood or whole blood, if that ambulance only had pack cells, I would have them give pack cells, or the helicopter, if they're just carrying pack cells, give the kid pack cells. If for some, and there's now some places that carry plasma, if they were carrying plasma, I'd say give them plasma. If they have whole blood, give them whole blood. I don't think there's an age limit where that would not be a good thing.
Dr. Gaines, thank you so much.